just to stand with us for some questions. Yes, please. Okay.
It's a question for Offer. Do you think there's a use for hydrogen peroxide in the prevention of Cutibacterial acnes infection? And besides that, do you think there's a role for negative pressure wound therapy also in the prevention and treatment of these kind of infections?
I mean, you're great. Your questions are superb. Yes, not in primary, but when I do a revision, I use peroxide. When I wash out, I use peroxide as well. I don't know if it helps or not, but I believe it helps because, you know, it causes something. So, yes, you have to do whatever you can to try to avoid further infection. And regarding the suction, one trick that I do, I never use drains in my primary or any operations. What I do is I leave the suction, when I close the deltoid, I leave the suction under the deltoid until I closed everything. So I reduce the dead space. I have no, when I take it out, actually everything is collapsed. Because you have a tamponade. If you close everything and you keep the suction and close everything, you have a tamponade. So it will, at a certain point, the bleeding will stop. So you have less blood in this big dead space that you have. So you have less dead space. It's a good idea. I didn't have time to tell it in my Relive, but that's important thing to do.
Can I ask just one more thing?
Yes, of course.
When you do the beads, do you
Yeah.
change the dose of your IV antibiotics?
No. First of all, I give IV only perioperative, so 1 dose or 2 doses, not more than that. And the rest, if the patient doesn't have any problem with his gut, he gets orally straight away. There's no, if he's good absorption, he doesn't have to have it IV. I know it's different from what other people think, but our microbiologists feel very strong about it. So, but it's important to give the double drug, because you need the rifampicin to go through the microfilm.
May I add something?
The biofilm.
May I add
Yeah.
something? About these beads, I use these beads too, and the problem is that these are producing quite a lot of fuel after the fluid, after the operation. So for the first week, you will see that the wound is draining quite a lot. This is frightening.
That's a good point. You shouldn't put a big chunk of them just under the skin. You have to spread them between the tissues and just a little bit under the skin. Because if you put a big chunk of them, that might happen. It can drain out.
Always.
Not
I
always,
do
no.
the same thing as you do.
Thank you.
Okay. Any other question? Yes, Tom.
Just a remark. Cutibacterial acne is a serious problem, but I don't think we really know enough about it so far. You're probably aware of the paper where they also cultured sterile swabs as a control for the swabs they took from the patient, and there was a considerable number of positive swabs also in the sterile culture from the sterile swabs. So Cutibacterial acne is a very strange bacteria, and probably extended culturing in the lab creates false positive results. So that's one thing. The other thing is that Cutibacterial acne is not Cutibacterium acne. There are different strands, and they have different pathology. So I think we should be aware of that this is a lot of knowledge to gain still.
Correct, everything you said is correct, but that's why we were very strict. We took at least 5 to 7 specimens, and more than 50% of them had to be positive in order to be positive. That's one thing. About the strands, you're right, and we are running now an international multi-center study in Europe, supported by SECEC. Robert Hudek is the chief investigator, Carlos Torrens, myself, there's a few others. I mean, we are quite a big number in Europe. I will regard myself as European yet, yeah, still, yeah. In Europe, we're doing this multi-center study from revisions to find which subtype of P. acnes is the one that culprit for the infection. And I'm sure that there's so much more to learn about it. And we're just scraping the surface, yeah.
That's very interesting, yes. So, any comments from the other gentleman, Dr. Ferrusis, Dr. Mafala, about that?
I have a comment.
Yeah.
It's great presentations for both of you. But again, you can prevent everything by using a stemless implant.
That's good.
Also
Not-
glenoid
not-
loosening.
Ah?
Also glenoid loosening.
No,
Yes.
yeah, that was I was about
Yes.
to say, or rupture of the calf.
No, yeah.
Thank you. Let me ask you, to each one of you, which kind of washing do you use during your routine reverse or total shoulder arthroplasty?
Well, I just use, I do a double prep. There's one obscure paper somewhere, I think in the total knee literature, where if you double prepped with betadine and then chlorhexidine, the infection rate was lower. So that's what I do. But I don't use any peroxides or anything
But
fancy.
on the skin and inside when you washed?
Nothing.
You mean
nothing.
washing
Implants?
during the
Inside.
operation?
Oh, inside.
Yeah.
Oh, no, the United States, they actually made it, I mean, it's like not illegal, but it's not the standard. And I think some regulatory agency made everybody stop. So we don't use anything. You can only use saline,
Yeah,
With pressure or just,
just squirt.
okay.
saline the same.
With pressure or
No,
Just-
no, just like
offer?
Are
and
you
sometimes, sorry, diluted betadine, sometimes.
Okay.
I use saline, and whether with pressure or not depends which hospital. The private one, yes, with pressure. The NHS without pressure.
That's good.
Don't ask me why.
Does anybody use something else here?
So I prep with peroxide, because
Okay.
usually it takes me, unless it's a revision arthroplasty, everything takes me about an hour.
Okay.
So if you use hydrogen peroxide, it'll kill C. acnes for about 1 hour. So if it extends past an hour on whatever I'm doing, then we'll wash with peroxide again, dilute betadine, and then saline. So I think C. acnes is a very serious problem.
Yeah.
And so we changed our prep, I don't know, 4 or 5 years ago, whenever when Alex just started the PJI task force. And so we changed that. We found that it killed it for an hour. So we do that. And then the nurse in the room watches the clock. If it gets to 60 minutes and we're not closing, then we'll wash it with peroxide again.
Inside.
So both outside, so the outside prep is sort of like what Ed said. It's peroxide, alcohol, chloroprep, and then we do a second chlorhexidine prep after we drape. We change gloves. We open the shoulder. If we're going to irrigate inside, we do peroxide. If it's past an hour, then we do peroxide and then dilute betadine. If it's not past an hour, then it's saline wash. And then I went back to using a drain. So
Yeah.
I do a drain. I know you don't, but
I'm not using.
I don't like hematomas at all.
I don't have any hematomas.
Yeah, I know you don't, but I don't use stemless on the humeral side.
yeah,
So clearly,
correct.
I have hematomas.
Correct.
That's right.
Soon it will be available.
Those big
Soon.
stems bleed more. So I think it's really interesting that and you can probably comment on this, is that it's sort of the standard of care in the States is a two-stage revision. And if I can't comment on the medical legal side of it because every case is different, but by and large, the mentality in the states is you should do everything possible to make sure there's not an infection. So if you're going to replant somebody and then they get infected, like you do a one stage, and they get infected and have to have a more operation, can't say that that's considered malpractice, but it's considered poor form, and at least. And probably, I think in some instances, there would be litigation involved. And so it's interesting to me that despite what the single stage data seems to show, that across the pond there, the standard of care is a two-stage. And I think part of the issue, the biggest issue I think for me, is that everything, or not everything, but almost every revision, no matter what sort of soup you throw in there, will grow one colony of P. agnes in broth, or C. agnes in broth, or maybe two colonies or whatever. And even in that situation, the risk-benefit ratio of not treating it is considered too high to not treat it. You know what I'm saying? Yeah. So maybe it's fear of litigation, or maybe it's fear of having to operate on the patient again. I think the standard in the United
But I
States
think-
is a two-stage revision. And,
But
and what's interesting to me is, you know, this sort of the systematic reviews for
It's
the
from the
past
States.
for the
It's
past
from the
10 years
States.
have shown the same thing. Well, I did one too, and I was
Yeah.
a co-author, but
Yeah.
you know, the data is the data, you know.
Yeah.
So
But
I actually didn't read it.
But I think again,
I'm just joking, of course.
but I think that again, that's not a problem because, for me, even if it grows nothing, and I suspect that it's infected, it's infected. You know, the fact that we didn't grow anything doesn't mean. So I treat it the same as I will treat infected with C. acnes. So I use the beads, I'll give antibiotics for at least 4 weeks, check the patient, see how it goes. And
But
then
even-
if I need, I continue with antibiotics.
But even
further.
something oral versus IV,
Yeah.
you know, the trouble, and you were talking about the way you do the skin and everything, the trouble is ever getting enough data, I mean, enough numbers to actually get statistical significance so that you
Correct.
can actually make real comments or conclusions.
But-
I mean, most of it's sort of voodoo, you know, like you got your voodoo, he's got his voodoo, I've got mine, you probably have yours.
But
And it's all, so until, and I think it's gonna take, because the numbers are so small for most of us.
We need to do
it's gonna
probably,
take-
we need to
exactly.
collect all our data together
Exactly.
maybe and do it
Exactly.
together.
May I
And that's a
make
good
a
plan.
comment that regarding the 1 and 2 stages?
Yeah.
The difference is, it's true that the results of the 2-stage procedure are worse than the 1-stage procedure, but the reinfection rate is the same. The
No.
results are worse. Well,
This
that's-
study, you know,
I wanted, to
meta-analysis
say,
shows.
I wanted
yeah.
to say that the results are worse because of the function. And this lot, it's something that can be explained
Yeah.
if you go to eyes for the vision. But as far as I know, I was checking that recently, the great majority of the literature show that there is no difference in the reinfection rate.
I mean, one thing that I think it's important to say. I mean, obviously, like some of us that are centers that collect infections from all over, I've got quite a large, revision from other places. And to be honest, if I try to remember how many of these one single stage I did, I have to go back and do a 2-stage. There's one of them I showed you now, and another one I can show you that's that I had to. So I tried to do a dare to preserve everything, just change and wash and all that, and it failed. And maybe it failed because it was too late to do it. And these two I had to do a 2-stage.
Okay. Professor Yurgoulis, another question.
I have a question. You said that when you suspect an infection, finally, there is an infection. That means that you have an experience in infections, and there is accumulation of signs or criteria that lead you to
very
suspect an
simple.
infection. What is this?
It's very simple. You have painful stiff shoulder,
Painful stuff.
stiff shoulder.
Pain.
You look at the x-rays. You have loosening, aseptic loosening. You don't have any CRP, ESR, and all that. It's, for me, until proven otherwise, it's infected.
Without CRP, without...
CRP will be normal
fever.
with C. acnes. It will be normal in most of the cases. ESR will be normal.
Okay.
So everything will be normal. For me, painful stiff shoulder,
And losing?
and even without loosening. But if there's loosening, it's infected. Yeah.
Can I ask
And I
something?
tell you that the majority of cases that I suspected that will be infected, when we took the specimens from the canal and all that, all the specimens came back positive for C. acnes.
Yes. Is any case to suspect the people, I mean the patients who's maybe develop this infection from the others? So to give prophylactic some kind of antibiotics?
This is anecdotal. I can't, it's no science,
Yes.
okay? I have a patient, if I have a patient that come to me with a painful shoulder replacement, I put the patient on the double drug
Yes.
for 2 weeks.
Yes.
And I ask the patient to come back. And if the patient come back and he feels better, that's another, sign that it might be infection.
Yes, of course.
But I have no signs of that. I can't write it because it's anecdotal.
Yes.
Yeah.
No, I say before the operation, just in case, a candidate for a shoulder arthroplasty, can you suspects for some reason something?
All the
Or
patients that we've seen that were positive for
Yes.
C. acnes in the joint
Yeah.
had no signs of infection prior to surgery.
Yeah, okay,
No
thank you.
signs.
In any case, I think there's a paper about doxycycline for something prophylactic for 2 weeks or something like that. Do you
Yeah.
have any?
It's a good idea. I don't know. I'm not
Okay.
using it, but
Okay.
it's I think, Buddy, you
My
mentioned
question
it.
is about
Yeah?
antibiotics, and maybe you answered it now, but
Yeah.
I wonder if you always use rifampicin, because I don't think it's very strong evidence for that either. I agree.
No, in the infected ones.
I agree that you should use two types.
Yeah.
But do you
The
always use rifampicin?
Yeah.
The others as well?
For
Always?
C. acnes, yeah.
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 Yeah, but not for C. acnes, but for an infection in the shoulder before
No.
you know. And
No.
No.
Oh, no.
No, it depends on the bug. If you know the bug, you specific for the bug.
Yeah.
If you don't know what the bug is and you suspect C. acnes, or you know it's C. acnes, you
and
must.
you always use it.
Yeah, and if it's a bug that creates biofilm, I use the rifampicin. You must use it because otherwise it protects itself with a biofilm and any antibiotic will not work.
Yes, you're very categorical, but other people disagree with you that you have to use it.
Okay.
That's nothing new.
I'm saying my stuff very loud and all that, but you know,
But you know,
you take it or leave it, you know.
actually, rifampicin has a
Can I ask
synergistic
also
effect
Dr. Ferrusis,
with the beta-
for practical reasons, what about the change? Is you prefer to revise an anatomic stem or just to change? What is better for you? What you prefer?
What do means the conversion?
Your conversion, exactly.
My question to Professor
You mean that
Because we know there's
platform
some
stem?
difficulties. Yes, exactly.
I have never convert a stem.
Yes.
It's in most of the cases it's not
Revised.
possible.
Okay.
Either to the height, mainly to the height,
So
and you have to revise it.
yes, this is a meaning. I mean, a message also for the companies. For the
It is. I mean, I think all this conversion is a nice gimmick, but
Yes.
in most of the
Yes.
cases,
Yeah.
it doesn't work.
All right.
Very limited. I know that Alex managed to do it. I know that you managed.
Yeah, yeah.
Correct. 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 But you know, this is when the first surgeon got it right.
Yeah.
But when the first surgeon got it wrong, it doesn't matter. You have to, you know.
So, gentlemen, thank you very much for your participation, for the talk. Oh, so the last one, yes, please.
my question to Opherly regarding the approach, as you showed us like anterior superior approach and the McKinsey approach, but I think that you must be using the deltopectoral approach for your fracture cases and your revision cases also.
No, I for the fracture cases, I use the same approach because you can work from this window and do everything. Again, for the fracture cases, I have to use a stem, but I can get into the shaft from the top, and I use the thinnest stem that I need because I use it cementless with bone impaction, the same. For revision cases, I sometimes have to think whether I need to do a double approach. So usually the cases that are referred to me with a stemmed implant were done through a deltopectoral approach. So what I do is I use the skin incision that they had, and I extend it superiorly like a saber cut, take the subcutaneous to the side,
And go through.
and go do arthrosuperior approach. If I'm unlucky to get it out, I close this and I go to a deltopectoral approach.
Thank you very much. Okay, please, we're done. Maybe later on with the coffee or at the supper. Thank you very much.